So, Dr. Kim, could you introduce the live case?
Yes, let me introduce this case.
All right.
Yes. This patient is 78 years old male without apparent symptom was admitted for abnormality finding of coronary CT. He has a long-standing history of the diabetes. So CT revealed that he has a three-best disease with heavy calcification. The next. His coronary artery disease risk factor is diabetes and hypertension, hyperlipidemia. And his clinical presentation is stable angina. Next. The echocardiogram revealed that he has a preserved cardiac function, but we did not the function study such as the thread mill and thallium, but the coronary angiogram he has functional. We did the functional study using the FFR. The ICA has a positive, and the left coronary artery system is also to have a positive FFR finding.
So RCA already treated.
Yes, already treated using the two stents.
Okay. So today we are going to treat the left main to the LAD systems. So this is epicaudal view. Can you see the very calcified coronary artery? Considering the very patient age, I don't pay attention to the circumflex. I only focus on the left main to LAD disease. FFR is 0.62, very significant FFR value. So I think we have to correct LAD.
Would you show us another view?
Next, please. Yes.
Oh,
Very diffuse calcified. You can see
Right.
the calcium surrounding the vessel.
very small.
Next,
However, heavy fluoroscopic calcification from the, proximal LAD, main, and to the mid portion of LAD, too, right?
Yes. Next, please. So this is very interesting. This is not stent, but the calcification. So because of long-stand diabetes and older age, we can explain the very severe vascular calcification.
So what would you do there?
So how to treat this patient?
Antonio.
Next, please. Insert.
This would be an ideal case for shockwave. If you had, without shockwave, I would still try first high pressure balloon, but maybe to add the cutting balloon high pressure. I will do both. IVUS is important to check the size because eyeballing looks small, but it's definitely trio. So I will do IVUS to check for size, then cutting balloon, high pressure balloon. Rotational atherectomy is a possibility, but the residual lumen is not so small, so you need to use a big burr, and to do a long lesion like this, you get a lot of embolization. So I first try with other tools.
Yeah, I agree with Antonio.
Okay, thank you, Antonio.
Dr. Ann, I think one of the questions is up to where you will put a stent. Because the lesion is very long, up to this small diagonal branch that we see in the bottom of the screen. The second question is protection of the two diagonal branches, because it's just purely ostial lesion, especially the second one. I'm not sure that I will put the stent there, just protect it. And the last question is the left main significant? So when you have done FFR, did you check all along the vessel where if there is some drop of the pressure? So is the left main really significant by FFR, or is it only this long lesion of the LAD?
Sometimes what we do
thank you, very nice question.
When we have this long lesion is to do an hybrid, place a short stent and use drug-eluting balloon also. I know that is not standardized, but we like to do.
Why did you do that, Dr.
Okay, so thank you for very nice questions. First, how long I have to treat? I think it depends on the IVUS finding. Basically, very diffuse disease. So I have to decide the distal landing of the stent. I cannot implant it. I cannot make a full metal jacket from left main to the distal LAD. I just want to implant stent in the middle LAD. So based on the IVUS finding, I will I will search for the best landing area for distal stent for distal stent. And next question is how to keep the side branch wire. So basically, we can predict the side branch fate. So no one blame that whenever I insert the wire to the side branch, as Antonio said already. But based on the angiogram, second diagonal is acute angle, but the first diagonal is more than right angle. So based on my assumption, first diagonal branch is low risk of jail after crossover stenting, but second diagonal may have a higher risk of jail. So I like to insert jailed wire to the second diagonal branch. And then based on the FFR measurement, the pressure wire pullback, that this patient have diffuse stable pressures. You can see the IVUS, the whole LAD territory, there are disease. There is disease, so including the left main. So I like to cover the left main to some part of mid LAD.
So what did you do
Next,
that non-compliant high pressure inflation or cutting balloon?
After insert wire to diagonal branch, first I like to see the IVUS. Could you show us the IVUS? IVUS cannot passing through the below the diagonal branch. Yes, this is actually encircling. This is above the diagonal branch. But I can guess the vessel size roughly around the 3.0. Very severe calcification surrounding the 360 degree. Usually rotabulation is necessary, but I try to make region modification by using high pressure balloon first. If the high pressure balloon cannot passing through the lesion, then definitely we need the rotabulation.
Right.
Here is the left main. Left main minimal lumen area is 5.0. But there is a significant lesion, so I like to cover the left main.
My personal opinion is second diagonal is compromised, ostial part, and then there are some disease in the first diagonal branch too. In order to protect the compromised side branches, I think it's a debulking. It's kind of a rotablation if possible. That would be the one of the good choice. Rotablation first. Maybe we don't worry about the compromise of side branch. Oh, you have already passed the wire over the second diagonal, right?
Yeah.
Depending on
Unfortunately.
Right.
So, yeah. Next, I applied 2.5 high pressure balloon because based on the IVUS finding, vessel size is definitely bigger than 2.5. This is 2.5 high pressure balloon. I applied very high pressure, 20, 24, 28 something. Next, several times.
Break.
Next. Then some dissection. Then I evaluated IVUS. Could you show us the IVUS? Can you see starting with the below the diagonal branch, the angiographic normal looking area? Please show us again the starting area. Here is a very minimal plaque, vessel size 2.5, minimal plaque. So here is a presumptive distal stent landing area. Just above the presumptive stent landing area, heavy calcification is started. Vessel size is 2.5 here. You can see the dissection due to the ballooning. and septal branch is coming, diagonal branch is coming. You can see the wire. Above the diagonal branch, vessel size is getting bigger, more than 3O.
Some cracking.
Fortunately, the
Is that going to
high pressure
count
balloon
12
25
o'clock,
cracked
11
the-
o'clock, right?
Yeah,
Great.
yeah. You can see the breakage of circular calcification.
Yeah. 1 o'clock, 2 o'clock.
Is
So-
not,
So I applied only 2.5. I think before the stent implantation, we need a better lesion-free modification. So I like to apply the higher pressure balloon, bigger balloon. So this is a 3O high pressure balloon. Next. So, okay. Here is your left main.
not bad.
Okay, stop. Previously. So I was I was started at the point of. Can you see the mid LAD normal looking area? So I like to implant the stent from the mid LAD below the diagonal branch, and then I apply the high pressure again. Next, please. 2.5 high pressure. Next. We have to check there is a balloon indentation. If there is a balloon indentation, then we need more aggressive the precision modification. But fortunately, balloon is well expanded. Next, please. Next. Some dissection. Next, please. This is 2.5 based on the distal vessel size, 38. Next, please. This is 3.5, 23, based on the IBUS finding. Next, please. So this is a 2.5 high pressure balloon because distal stent vessel size is only 2.5. Next, please. High pressure, several times high pressure. And this is a 3.0. Next, 3.0. This is 3.5. Next, please. 3.5 up to 28. Next, please. Next. So next, please. I also applied again after I was evaluation. 3.0 high pressure up to 28. Next. 28. Next. So this is your final angel.
Great.
Could you show us IBUS?
All right.
Compare
So-
with the baseline angiogram, vessel is getting bigger, and IBUS show that can you see the IBUS? Here is distal landing. Yes, based on the IBUS finding, we
2.5, so
implanted
fine.
stent distal on the very minimal plaque area. The lumen is a little bit small, but considering the vessel size, I think this lumen stent area would be fine. There is some eccentric stent expansion, but considering very high, because this is due to the very heavy calcification. Here is below the diagonal branch. Diagonal branch is coming, and then vessel is getting bigger up to 3.0. Can you see the breakage of some calcium? Here, the lumen diameter is more than 3, very expanded, without tabulation.
Great.
So if the high pressure balloon passing through and then high pressure balloon, there is no indentation, you can modify it, you can achieve the good precision modification by only use high pressure balloon. Sometimes it is more predictable and then sometimes safer than tabulation.
Yeah, very nice.
What is the maximum
Circulation
pressure,
is coming.
Dr. Han? What is the maximum
20
pressure
28.
28.
28?
28.
All right.
sometimes
what type
28
balloon? What type balloon
ruptured.
do you
So
use?
What type balloon?
just
Non-com-
the routine high pressure, routine non-compliant balloon, not that special balloon. We don't have OPM balloon. So could you show us on that last final NGO? Previous. This is a final NGO.
Perfect.
So when you compare the baseline NGO, vessel is getting bigger. The I was guided, we implanted the stent, distal landing. I selected the stent length and stent size based on the IVUS without rotabulation. The only high pressure balloon I applied, the make a good region modification, and I can achieve the good stent expansion.
Right.
Next,
So,
please.
A clear
So this is
message from
spider
this
view.
these cases. Actually, even heavy fluoroscopic calcifications and non-compliant balloon high pressure work in almost all cases. That is our. So, Dr. Ang, how could you define what when what cases do you do root ablation first? As in almost all cases, we can solve non-compliant high pressure inflations. However, when did you consider root
My
ablation at
criterion,
first?
the absolute indication of rotabulation in my mind is are the two things. The first, the impossible to deliver the device, high pressure balloon or something. The second is high pressure balloon cannot dilate the lesion fully. So high pressure balloon cannot passing through, or high pressure balloon cannot dilate, then we have to do rotabulation. Otherwise, I like to start with the high pressure balloon first.
I have only one concern.
Continue.
Excuse me.
I think there are two philosophies. One is what you just said, that to do rotablation with the idea to minimize. The other, some people use rotablation when they see a lot of calcium. I think a little bit in between. I rarely use 1.5 balloon, 1.25. If the IVUS does not cross, or if the non-compliant balloon does not cross, I don't take a small balloon, I do rotablation. That to me is a simple decision.
But Antonio, is there some cases where you decide upfront to go with rotablation, or you always try with non-compliant balloon?
No, if there is a lot of calcium, it's nothing wrong to do some rotablation that was not absolutely necessary. It's not the end of the
I
world.
think the concept of SG, which was said just at the beginning, to use rotablation to preserve the side branch issue, I think it's a good one, because by removing the plaque in front of the side branch, you decrease the risk of carina shifting or plaque shifting and the risk of side branch occlusion. Now we see that the diagonal is pinched, but it's a small one, so I think it's not a relevant diagonal.
Okay,
So
all
I
right.
think- yeah.
Great, Dr. Ang, great cases. Good live demonstration. Okay, we're gonna move next room.
Thank you.
Right.
I have
Good last cases.
The problem when you do these long lesions, if you measure CK and B and troponin, always are positive. At least 3 times.
Of course.
Michael, can you hear me?
Dr.
All right,
Park
great.
and Dr. Colombo, Dr. Lefevre.
Very handsome.
It's a pleasure to be here.
Yeah.
It's my first time doing it in front of live living legends, and both of you, 3 of you, so it's a pleasure. So Dr. Kang is going to present the case. Dr. Kang.
Yes. The patient is 70-year-old gentleman referred for failed PCI in another hospital. He complained of chest pain and diagnosed unstable angina and 2 vessel disease 3 months ago. They thought it was unsuspected thrombus RCA, but no change in our angiography. Next. The patient had history of hypertension, and next. And the echo showed the moderate LV systolic dysfunction of LV ejection fraction 45% with RCA, wall motion abnormality. Next. And the angiography showed some severe tight stenosis on RCA and diffuse stenosis on LAD, and we treated LAD 2 days before. And now the target is RCA.
Great. So let's start with the first angiogram.
Yes, this is the first.
Okay, Dr. Park, can you see the angiogram of the right coronary?
Yes.
Yes, you
Yeah,
can
we see.
clearly see that.
Okay, great. So as you can see, the mid-RCA has a filling defect, most consistent and suggestive of calcium. Next.
Next.
So, just kind of gave it away. So, you know, if you think about why there was a failure from the previous hospital, I think it's because they probably couldn't wire it or they couldn't advance the balloon. Now, this is quite a challenge. Now, if you look at the guide catheter, there's very poor support, and in retrospect, maybe I should have used a 6 French IM, but this is what we have. Now, what I did right here was a little Dynaglide just to get the burr a little bit forward and clock the catheter, Dynaglide again. Eventually, we were able to get the 1.5 burr down. Next. So we made several passes. It's 150,000 RPM. Was able to cross reasonably easily. As you can see, the guide catheter is really not great at this situation. So I think the vessel probably is going to be at least a 375, if not 4 millimeters. So my next step would be to do a 175 rotational atherectomy burr. Now, what I'd like to show the audience is the following. So just to give you a background, you know, having people like Dr. Kang assist is very straightforward to do a case, but imagine if you're doing this case by yourself with an inexperienced assistant. So when you advance this rotational atherectomy device, sometimes the person that is assisting you could pull the wire back. So I said, what can I do to kind of have control? So what I've devised is what's called a single operator technique. And I'm going to kind of show you what I do. So I'm going to go in fluoro, and what I'm going to do is put the device right next to the TUI burst, okay? And basically, I can advance this by myself. So as I'm advancing the burr with my left hand, I'm pulling back the wire.
Just wait a moment. The camera is not showing your hand. Can you please show his hand and device? Okay.
Great. So you look at my left hand, I'm advancing the burr, and with my right hand, I'm pulling back the wire. So just kind of simultaneous. Okay, so it should be coming around. So this is what I term a single operator technique.
Great.
It should be visible. So this is where I had difficulty before. So I'm keeping a good eye on the guide, the wire, and I'm already meeting resistance. So at this point, I'm going to do a quick Dynaglide just to get this catheter. So let's put the brake on.
Brake on.
So I'm going to straighten this out just to make sure we, okay. So here we go, just a quick Dynaglide, just to go a little forward. Okay, good. So we're going to try this again.
You know what we do, we keep the brake open and we go down from the very beginning with Dynaglide. And you don't need to hold the wire, nothing.
Okay, here we go. So this is got to be very careful not to dissect the ostium of the right coronary. So I'm just going to go on Dyna and see if I could just advance this. Good, perfect. So we'll give a little break. Great. Now let me see if I could advance a little bit further because I don't want to spin all the way from up here. All right. So some resistance. This brakes on. I'm just going to Dyna down, glide this a little bit further down. Okay, good. Let me see if I could get this a little bit further down. Probably not. Let me receive my guide. So again, guide support is very critical. I'm going to clock it just a bit more, make it a bit more coaxial. All right, let's just start from there. So I'm going to go up Dyna. We're going to go at 150,000 RPM. Brake is on. Saline flushes. Ready?
Yes, saline flush ready.
Here we go.
175 per side.
Okay, some resistance right here. Be very careful. I don't want this thing to jump. Let's give him a break. Okay, good. His heart rate's great. We don't have a pacemaker. I think so long as you minimize your passes, the risk of any hemodynamic or electrical instabilities should be okay.
So, Dr. Lee, do you inject some contrast before each pass or not? I'm doing that because
Yes and no. In my experience, by giving contrast,
capillary flow, and so it reduces the risk of
possibly. In
flow or
my
no
experience,
flow.
whenever I give contrast, the wire gets very sticky and it gets hard to take out. So I've avoided that in my experience. Let's try this one more time.
I
See any
always do
flashes?
that.
Ready?
Yeah, ready?
I think it's a good point that it's like adenosine.
Exactly. So it's like injecting adenosine at each pass.
Okay, we're making progress here.
You don't need to take
Okay, we'll
it.
come back, give him a little break.
Already there.
So, Dr. Colombo, I work with John Tobis, one of your colleagues, and before I used to use in the rotoflush, all the vasodilators, but everybody would get hypotensive. So we follow your paradigm. We give 10,000 units of heparin in one saline bag. So that's our heparin flush.
Yeah, we
It's
don't
cheaper,
put
too.
any nitroglycerin, verapamil, or stuff like that.
Yeah, they get very hypotensive. All right, I think one more
Dr. Lee,
pass.
Dr.
I'd
Lee,
like to.
I have a
Okay,
question.
saline
So
flush.
this
Yes.
patient is
Yes.
LAD, severe stenosis, and when you do some RJ rotation, so actually we need a pacemaker. So you don't have the insert of the temporary pacemaker for this
Well, the
patient?
LAD has been revascularized. It's stented.
Already stented. LAD?
Yes.
And the other thing, we don't put temporary pacemaker anymore. We give aminophylline, 250 milligrams, 100 cc.
Okay, I think that should be good enough. Let's done and glide out. Let's disconnect the
Yeah,
brake to the
I
end.
agree with that. So I don't use aminophylline, but I think the secret is to do short passes, inject contrast after each phase, and stop before AV block. Of course, you don't know when you will have AV block, but if you do short passes, you inject contrast each time, the risk of AV block is very, very low. So we never use a temporary pacemaker, and in case of AV block, we can use a wire
break
to
off?
do
Yes.
simulation, like we do for TAVI.
Okay, so I'm going to hide this wire, and I'm going to use this rotofloppy wire to act like a buddy wire because the guide catheter is not completely stable. So we're going to give a little puff right here just to make sure there's no disaster, and then, okay. Test, please.
Test.
Great, okay. So let's get the balance, or the BMW down, and then let's IVUS after we get the BMW down.
So, Dr. Lee, it was a 1.75 burr.
Yes,
Yeah.
we first treated it with a 1.5, then we upsized to a 1.75.
I think because there is still a big stone in this mid right coronary artery. So I think that
Yeah, and we talk about the paradigm of treatment of calcified lesion. It's not so much debulking, but more plaque modification. And we'll see with IVUS what we've done. And if we need to go with the 4.0, I'm sorry, a 2.0, it should not be a problem.
because I think that shockwave can be a very good tool in this kind of case.
No, you are absolutely right. I think it would have crossed reasonably well. Puff. Just want to make sure I'm good.
Even a localized scarification. Not
Yeah,
constant.
this is because you will break the stone. So then expansion of the stent will be very good. The other point
Okay.
is
So let's
when you have
IVUS
this kind of stone in the coronary artery, very good to start with a very good support, which is not the case.
Okay, good. Hold on. Yeah.
So of course you can use extension guides, etc. But in this particular case, I will start with the 3D right, which gives you a very good support without the risk of the implants. So if IVUS is not crossing, what
Okay,
will you do?
let's see if we make this true. If it doesn't cross,
Yeah.
it crossed nicely.
Okay, nice.
Let's start the IVUS now.
Oh, it's good
Okay.
because it means that you have already done a good job with rotabulation.
More than 4
All right.
millimeters.
Dr.
Yeah,
Kang, if you
vessel size is more than 4, very large vessel, and you can see the calcified nodule that's protruded into the lumen. That will be the culprit, and now the lumen here, lumen is okay. Let's see. Okay. Here, there's another calcified nodule that's protruding into the lumen, and here, very severe calcification encircling the lumen,
yeah.
and there is some breakage, and still, but protruding calcified nodule is obstructing the lumen. And after passing the calcified nodules and severe calcification, the vessel size is very big, about 5.0. And some calcification still, but the lumen is large here enough. Yeah.
Okay, so we're going to take this out. So let's talk about what we should do next. Should we try to see if the balloon fully profiles or do some more atherectomy with a larger burr? I'm leaning more towards just seeing what we have a 325 NC balloon on the table. I want to see just how it expands, and let's try that. And if it doesn't fully profile, we can always go back and do more atherectomy.
I will try with the high pressure balloon. Which size? Which
Well,
size balloon?
we pulled out a 325 NC.
Don't
I'll
you
go
think
very
it's-
high pressure, but
it's-
I don't want to waste it.
It's too small.
I know.
Yeah,
I would have
the
probably
vessel
done a
is small.
3.5 or a 4.0, but the problem is I already opened it, so I want to make sure I don't waste it.
I think it will be a good test,
Okay.
but not
Yes,
enough.
yes and no, because even if it inflates well, you still
Okay, I got it.
may have another millimeter to gain.
Let's see what happens. We could always go with a bigger balloon and see what happens.
And also because it's an eccentric plaque, so you will push the normal part of the vessel.
On the side.
Yeah.
Okay, so I just torque the guide, get a little bit more coaxial, and let's see if this goes. Okay, let's get a guide liner, please. Or Guidezilla.
Guider.
Dr. Lee, you put the wire more distally is the very big RCA. Your wire tip is only in distal RCA.
Yeah, it's come back slightly. I think a guide liner would be very helpful just to get a little more support. So you could, if you look at this, look at the shaft of this balloon, see how much tortuosity, I think in retrospect, having a long sheath would have been very helpful. Okay, so let's take out the rotofloppy and advance the got it. So here we're going to take the rotofloppy out. Okay. And so let's see how this goes. If it doesn't go well, we should get maybe a smaller balloon to kind of telescope this. Okay. And let's load the 325 NC.
3 to 5.
If it doesn't, the balloon we just have right now. If it doesn't go, we'll go with a smaller balloon. I think so long as we get this to telescope, we should be fine. Yeah, we should be able to go, I think. In the meantime, let me see if I could, so, got it. If this doesn't go, do you have a 2015 balloon, just so we could telescope it? And then we could get the guide liner further down. Now let's do this. Let's get a 2.0 balloon. Okay, actually I got a little bit more coaxial. Let me see if I can spin this wire down. If you could put the torquer on this, please. Actually, yeah, I need a torquer.
All right. Wire more inside the pack to the distal part. It can make it a little bit more stable.
Puff there. Puff.
Yep.
Right, great, great. It's more deeper, and right, fix up for a part is more, can make it
Yeah,
more
my
stable,
guide
right?
is a little bit off.
Chilla and proximal part, you have to be careful,
Okay,
right,
so
great,
let's try the balloon one more time.
great. It's more easier,
Okay.
right?
All right, puff there.
Great.
Puff. Let me pull back.
It was enough
Puff.
to have a good wire position.
Okay, let's go
Yes,
up.
very-
Let's go to 20.
8, 10, 12,
14, good.
14.
Okay, and down.
Maybe you
Well, that was
can
encouraging.
take
And now what I'm
advantage
gonna
of
do
the
is
inflated
guideliner.
balloon to
Yeah.
get the guideliner down.
Yeah,
inflated
absolutely. And then
balloon.
get my guide liner a bit
You
further
will
down.
not even occlude the corner
Yeah, so
floor.
I'm going to go to neutral. Let me see how this, go to neutral.
You can go with
The neutral balloon kind of approximates the diameter of a stent. And then I'm going to take this guide liner down a bit further. So I think we should be okay. Get my guide more coaxial. How about this? Let's do this. I'm going to get the balloon down a little further, guide closer,
Balance.
and then I'm going to
between-
inflate,
right,
and I'm going
right.
to get the guide liner down as far as possible. So here we go.
Yeah. When,
Okay, good.
when you have such a big
inflate.
corners, you don't even need the
Inflate.
guide liner. You go
And
with
then I'm
the
going
guiding
to advance the
catheter,
guide
inflated
liner.
balloon.
Good, and down. Great. Let's get a 4018 Zions, please.
All right,
And I want to
quickly.
move pretty quickly
All right.
because my
Zions.
Guidezilla is very deep. So let's take the, yeah.
The vessel is very large.
Your vessel is
Not an
large.
issue.
All right, you guys have the
Leave it
stent?
inside a
Yes.
couple of days.
All right, here we go.
빨리 줘요. 4.6.
Let's go.
예. 예.
You know, with this kind of lesion, usually I try to cross the calcium with the extension catheter in order to be sure that the stent will
Great.
cross, and then you pull back the stent.
I got it. Okay, I got both. Okay, let me pull back my guide liner now. Give me a puff, please. Come back just a bit more. Puff there.
Okay.
Puff. One more time, puff.
Up.
I think you can go up. Go up. Go to 16, please. 16,
So this is a 4
18,
millimeter stent.
20,
10.
and down. Okay, puff, please.
Up.
Okay, one more time.
Take it very
Let's go to 20,
Yeah.
quickly. Good. And down. Okay, let's take this out, let's take a picture, and then think about IVUS. Okay, I'm not going to even try to inject because a big balloon guide liner is not going to be great, so give me 5 seconds, we'll take this out and take a picture here. Okay. Okay, I'm just going to back bleed because I don't want any big bubbles to occur. Okay, let's spike the catheter, please. Give me a little puff. Okay, ready?
Great.
Inject.
Good. Perfect results, right?
Very nice, yes.
All right, I think we'll IVUS now. And any
All
other
right.
thoughts? Let me take the guideline.
Okay, Michael, you wanna be back
Yes.
in the after the introduction of the second lab here, right? Okay.
Great. And we'll show you the IVUS
Dr.
afterwards.
Pyong Lee, can you hear me? All right.
Oh,
Dr.
I
Lee.
can hear you. Hello.
All right, almost
Good
there.
afternoon.
Let's explain that.
Okay.
Your case.
Okay. Yes. I have my team, Dr. Hanbit Park and Dr. Aziz. So, Dr. Park, could you introduce our case?
Actually, our case is 73 years old male with diabetes, had upper chest pain. Outside hospital exam is available result of myocardial perfusion defect. So, and check the coronary angiogram outside hospital. Outside hospital coronary angiogram showed 3 best disease. So, deferred from outside hospital, our hospital. Next. He has diabetes and hypertension and smoker, and his clinical presence is stable angina. Next. He is echocardiogram with normal LV6 function, and next. This is
Okay, this patient is a stable angina patient with a typical effort-related chest pain patient, and he has a triple vessel disease. He has a CTO at the circ and the diffuse disease at LAD, and very, very tight stenosis at the ostium of RCA. Can we look at the...
오늘 NGO 보여주실까요?
Okay. Okay, so, all right. So
Ostium?
actually, this patient had a, yes, osteal RCA disease and the LAD diffuse disease. I just want to show you the LAD first. LAD 아까 그 cranial 보여주세요.
LAD 그 베이스라인이요.
원래 NGO 보여주시면 되는데 사실.
LAD?
LAD, 그렇죠. 네. Cranial view, please.
Okay.
No, this is not. Sorry.
앞에 앉아서.
Other patient. Okay.
앞에 앉아서.
Just show you the baseline. This is the LAD. So, in my view, the left main seems a little bit diseased, and there's a very diffuse disease starting from the proximal LAD, and we have two major diagonal branches at the distal portion. LAD is not that big, but very diffuse disease. If you look at the circ, it's like this. It's a CTO filling from the retrograde. The diagonal gives it, and the RCA gives it, and this patient has RCA disease like this. So actually, you already saw my practice, but I started to do the RCA because for the RCA it supplies the circ, and I thought that if I did the LAD, I had some risk about jailing the diagonal, and maybe the procedure would be a little bit complex. So I just wanted to fix the RCA first, which is relatively simpler than I thought that's simpler than the LAD. And then if it works, then I thought I would move to the LAD. So in view of this RCA, you can see there's a tight stenosis at the ostium, and at the distal, before the bifurcation, there's another stenosis at the distal. Every other was a little bit intermediate disease. So I will show you what I did. So I wired it first.
Great.
Ballooned at the proximal.
All right. I want to just mention
and
about
saw the IVUS.
Dr. Lee, it's a position of wires. You've seen just the previous cases, Michael Lee. I cannot talk too much. However, stability concern of the right coronary artery is unstable, not too much support. The wire is very important to, far distal impact of wire can make a whole, system make us stable, right? And so wire inside and the guider is floating in the outside of ostium, still we can walk some part. And so that is the most important part about ostial, unstable right coronary guider, right? Good.
Yes. Yes, right. So I fully agree. And actually, our practice, if we have a tandem disease, our practice is treating the distal first, because if you stent the proximal, it's really hard to pass some devices in the angulated proximal. But I actually decided to do the proximal for this patient because the guiding was not that good. And if I try to do the distal first, then I lose the guide after the balloon of the proximal, then the procedure will go very disastrous or very difficult. So in this particular case, I did the proximal stenting first.
Great.
So after balloon, first I would like to show you the IVUS finding, the first part.
Look at this. It's a
Pre-image,
picture.
please.
Actually, the wire tip inside. Anyway, the guider is not, just floating on the outside of those things. We can walk the balloon inflation and stent implantation, and so very important part to stability, to maintain the stability of a right coronary artery, the wire impact to the distal lead, right? There is a
One.
very technical.
Okay.
Okay.
One
Ostial
minute,
part.
distal부터.
IVUS.
Okay, this is the pre-IVUS. If you look at the baseline RCA, I thought that there is a landing zone at the mid portion of RCA where the RV branch is there. And this is potential distal stenting area. The vessel size is about 5.0, very big.
Big one.
This part almost 5.5 vessel. Lots of plaque, superficial calcium there. And a little bit of negative remodeling at the bending portion here. And this portion is at the proximal, I think. Okay. This is the proximal portion.
Let's see the ostial part. All right.
Yeah. Some branches here.
Tough.
And this is ostium. Actually, there was a dense calcium at the starting point of ostium. We did not see it fully at the proximal, but yeah, we did. We thought that 38 millimeters of stent will be sufficient for this patient. So I used the multiple views to appropriately position the ostium. It's very important to look at caudal view and cranial view for the RCA. And actually, I also intentionally positioned the stent proximal to the calcium that I saw at the cine. And then I stented it, 3.5, proximal.
Great. So 38.
And then
35.
after, yes, 3.75 balloon, 22, 28, right here. And this was our initial angio. And then what I did was, I wanted to treat a distal. There is an eccentric calcium you can see there. And I saw the IVUS first. Can we see the IVUS for the distal?
IVUS distal.
Baseline.
Do you want to treat them?
Okay. Yeah, this is RCA. This is the proximal portion of the PDA and bifurcation. You see a tight stenosis here, superficial calcium, very discrete. So the proximal and the distal landing zone is about 3.8 to 4.0, and the vessel size at the culprit lesion is about 3.8 to 3.9. So I selected to do a short stenting with the pre-balloon here, and then actually I used a guide liner to advance to overcome the proximal stent. I positioned the guide liner distal to the stented, proximal stented lesion, advanced it with a balloon-assisted technique like this, and then after viewing in multiple views, I used the 3.5 12 millimeter synergy stent. And then I use a 3.75 high pressure balloon.
Still under expansion.
Yeah, still diseased. There's lots of disease at the distal. And please let me show you the post-stent IVUS. I got the 3.75 to 22 mercury. So the distal landing is okay. For the this is the distal RCA. And as expected, the stent is a little bit elliptical.
Stent area is good.
And actually, we measured the stent area. It's about 7 millimeters square, which is not that bad.
Good.
And the proximal is okay. Okay.
Would you show
and,
us,
I will show you the proximal stent IVUS.
Dr. Lee, would you show us
Yes.
just, angiogram before the stent, distal stent procedure? I want to see the
Okay.
second lesion. All right, so right here we are. No.
Yes.
That one, right? I want to discuss with function concerns. Dr. Lee, you are Plumber, I know that, right? You are CTO guys. However, the distal part of a discrete narrowing, 60-70% stenosis, minimum lumen area, actually is a 3 centimeter square, something like that. If you do FFR, what do you think?
Well, it's a very difficult question.
Difficult, not too much difficult, right? Just
Is it appropriate to evaluate FFR in this context? Because we know that it will still give some outflow impediment to the stent. So why not to place a short stent there? It's a 3.5 vessel. It's a big vessel. You don't want to leave such a long series of stent with an outflow.
You mean you don't need a
FFR?
FFR?
No,
Just a stent?
just a
Okay.
short stent.
Antonio told you, right? Just a
It's a
stent, right?
3.5. It's not a big deal.
However,
One
in
concern
terms of
yes.
lesion morphology, is relatively discrete. 60-70% distal part of right coronary artery actually is in almost all cases a negative FF. All right, it's okay. Depending on a concept of a function, sometimes you're gonna, avoid unnecessary procedure. However, I think it's okay. Today is a complex PCI days, right? All right.
Okay.
Yeah.
And one thing I thought that I would not like to treat the circ because it's very diffuse disease, and it was not. I thought that it was not appropriate for stenting because it's too diffuse. We did not have any find out any stenting landing zone. So the RCA is a main supplier. So I thought that that would be one rationale to treat the distal too.
Great.
Okay, so
I think it is final. Final injury, please.
yeah. So I'll show you the final of the RCA.
Great.
Like this.
Look, perfect.
Yeah.
Perfect.
And you can see actually there is a, PL branch, there was a PL branch, and I think there was a wire injury. So I actually wired it again and did a long duration small balloon there. And then
Good.
the final was, okay.
Perfect.
All right.
So would you treat the left side
actually,
too?
we moved on to the left. Yes, we just started to treat the left side, actually. This is the left one. The circuit is occluded. We have a good radius intermedius there. And I think there is a possibility of proximal landing zone at the proximal LAD. And you can see a diffuse disease here. So what I did, thought that I would like, if you look at the morphology and the angle of the diagonal, the first diagonal will be okay. I think you will all agree. But the second diagonal you're looking at, the angle is
Narrow
not that
angle.
favorable, and there may be lots of disease. So after stenting, there will be some possibility of gel. So I like to use the protection of the wire to the second. And actually, the IVUS could not pass the distal, and I ballooned it with a 2.0. And can we see the IVUS? After the ballooning, I did the IVUS. So yes, run please. So this is the distal, far distal. The 2.5.
2.5.
A little bit of milking. Relatively normal. And disease starts from here, just below the second diagonal. So negative remodeled vessel, eccentric calcified part right here, and the vessel goes up. The size goes up about 3.0. Okay, so actually, I did not do a full IVUS for the proximal because there was a slow flow there, and I started to stent the distal. That's my current practice right now, status. Okay. So, do you have any comments for this procedure, LAD?
I think it's great. Just the two, diagonal branches. In terms of you mentioned about the angle, visual angiographically quite good. Look, first and second diagonal. However, second diagonal had some, steep angle, narrow angle, and so you have to protect that first, and the first diagonal would be okay for that, right? Okay, Dr. Lee,
Yes.
it's great,
Yes.
We will be back, right? And after our last case
you.
is start, TW, we'll prepare that one. Dr. Bach, can you hear me?
오케이. 오케이, 주세요. 2.5.
Dr. Bach,
주세요. 이게 LAD지?
All right. Let me show you what we did, Dr. Kang.
Yes, we applied 4.0 by 12 NC up to 18 ATM and approximately 20 ATM.
Good.
And this is the
perfect.
final image.
Here's final.
And we did IVUS again.
Yes. We also checked the final IVUS. The distal edge was clear and the vessel was well dilated up to 4.0. Here is the site that the ugly calcium nodule was present, but now the stent is well expanded and well opposed. Here there is a little bit the lumen size looks smaller than distal, but I think that the result is acceptable and great. We already applied 4.0 by 20 ATM. And proximal edge is clear without acute complication here. And the lumen was clear. And we also checked up to the proximal to the RCA ostium, and there was no acute complication related to the guiding catheter.
Great. Perfect. Right. Basically, calcific nodule, including the calcified regions, modification with the road ablation with a stent. All right. Thank you. Michael Lee, it's a good result.
Great.
Congratulations.
Thank you.
All right, let's move
Great.
on.
Thank you for allowing me to operate in your cath lab.
Okay. Dr. Han, can you hear me?
Yes, I
All
can
right.
hear you.
What will be the last
Dr.
one?
Jo, could you explain the... Yes, last one.
Okay, I want to introduce this case. This guy is a 72 years old male patient. He suffered from the acute chest pain. He actually, 1 year ago, he suffered from acute MI. So he underwent the PCI at the distal RCA to the PL branch in another hospital. And 1 week ago, we took the angiogram, and the angiogram showed the diffuse stenosis at the proximal to mid-aortic diffuse disease with heavy calcification, and circumflex showed the diffuse lesion from proximal circumflex to the OM branch. So at that time, we fixed the lesion with the synergy stent. Oh, sorry. Okay.
Okay, so we already fixed the RCA and then circumflex to OM lesions. So today we are focusing on the LAD diffuse calcified lesion. Another diffuse calcified lesion.
Could you
So
show us
could you show us
view?
another view?
Right. Different view.
Okay, very heavily calcified. You can see there's some calcified vessel. Next, please. Some angulation. Two side branch, the diagonal branch, and another small diagonal branch. Next, please. Next.
Very heavy fluoroscopic
So-
fluoroscopic calcification. Almost same.
Okay, I insert the wire. I like to, I tried to insert the IVUS catheters. I failed, so I applied 2.5 high pressure balloon. And then I insert IVUS catheter. Could you show us IVUS? Basically diffuse lesion, but if you, from here, there is some normal looking area. Angiographically below the big septal branch. Some balloon dissection here. Here vessel size is almost 3.0.
3.0. Calcium. Breakdowns. 4 o'clock, 5 o'clock, 4.
Yes, after.
All right, here we are.
So vessel size is 3.0. More than 3.0.
Heavy calcification, but not too. All right. 3 o'clock, breakdown.
5 high pressure balloon, please.
High pressure inflation. 1, 2, 3, 4,
Some
say
balloon
5.
dissection, you can see. Yeah.
Almost full.
Yes, proximal vessel is very big.
Encircling, almost.
Another, yeah. Proximal is looking very soft. Vessel is 4.0, almost 4.0.
Big vessel. Calcification.
Yeah. Another proximal lesion, and then this patient have very short left main. Diagonal circumference coming from the 7 o'clock. Here is your left main, very short left main. Okay, based on the IVUS findings, I'd like to apply the high pressure to break down the calcified lesion. This is a 2.5 high pressure balloon. 10, 20, 24, 28.
Jung-Min, I'm BK Kim speaking. So
Yes.
actually, comparing the previous calcified case is a very similar scenario. So your strategy also is similar with the previous calcified LAD region. So you first
Yes,
NC
similar.
ballooning, if failed, is translated
Yes.
to the rotation others, right?
Yes, right. Then now I have some problem. NC balloon is okay.
Yeah. In fact,
14.
there is a crisscross of the wires, so that's why you have some difficulty to,
Yeah, I think so.
to move forward.
20.
20.
Well expanded balloon, no indentation, depolation. 14,
14.
16, 18, 20,
20.
depolation, no indentation. 20,
20.
depolation. 20,
20.
depolation. Okay. Balloon is just smoothly moved to the distal.
So
I
there
like
is
inflation
a
further.
good sign of
14.
crisscross. When you push the balloon, you see the wire in the side branch going back.
Yes.
So it's a sign of
Yes,
crisscross.
depolation. Okay. So ready?
Good. First style
So
works.
please give me the two.
Compromise.
Definitely, I need one more wire. Yeah. Nobody knows the fate of diagonal branch.
Yeah.
I thought
That
the
big
second
sector
diagonal
is suffering.
may.
Yeah.
Yeah, right.
Do you ever put wires in septors?
No, I
Septal
don't
branches.
like to insert.
First style
septal.
works. Compromise.
Yeah.
Sometimes if they are very big, we
Yeah.
put wires.
Yeah, me too.
Because you get left bundle branch block sometimes.
If you fail the wirings, you do better to use the supporting device, Corsair or a microcatheter.
You know, retrospectively, when you have these long calcified lesions, I will prefer to do rotablation because
Yes, I agree with
because
you.
you get a little bit less side branch compromise.
Good. Good. Perfect. In the dissected main branches dissection, some may have sometimes to prevent
Test, please.
cross the wire of side branches. However, it's very good luck, good end.
Test. Talk, please. Talk, please.
So Dr. An, which kind of wire is it?
지금 또 시원 와요?
서포트하면 되니까. 자, 장갑 주고.
I think it's okay.
I think this is enough.
Alright.
Okay, 2.5
The
balloon,
later,
please.
do you want to see that?
2.5 balloon. High pressure balloon, used one.
Interesting.
I hope very simple procedure. But 6,
This diagonal is
not that simple. Depolation.
Push in.
6,
Great.
6, LED.
8, 10. Depolation.
Some disease, brother. One more. Good.
Ready?
LED.
Definitely we have to do
diagonal,
something. So,
You may need to do
yes,
double
please give me the
stack.
IVUS. Yes, I think so.
This diagonal is almost 20
옆에서
minutes.
어시스트 쓸게. 안 생각해, 어시스트 쓸게.
Oh, Titoru is
Gonna
coming.
be some time. you may miss the dinner. No, not, but it's going to take another half hour, 40 minutes.
Okay, diagonal branch.
I'd like to see the IVUS for diagonal branch. Along,
okay.
please.
Okay.
True lumen.
Less than 2 small.
2.
Yeah, true lumen. Fortunately.
Good.
0.0.
Or
Opening is
2.5.
big.
Some
Disease. Calcified black.
Okay. Please give me the 2.25 stand.
2.25 stand?
Yeah.
So what will be your strategy? You will do a crush technique?
Okay.
Yes,
What would you
cross
do then?
technique.
이거는 저기
I like to do cross technique because already side branch compromised, the floor compromised, and side branch is not so big, not so small. So we have to do two stand technique. So the second diagonal branch is bigger, but the wire is passing through the first.
first
so,
diagonal branch.
I like to implant the smaller stand.
2.25.
This is not due to the patient prognosis, but due to avoid the patient pain during the procedure. 네, 주세요. 2.25, 15.
Stent.
Yeah.
Okay, this is Resolute Onyx 2.25.
What is the LED size?
But is not only
What
for
is the
pain,
LED
size?
because this diagonal is going to give
2.0,
you a reasonable size MI, if you close.
Yeah. Oh, no,
This is diagonal branch.
Maybe wire kinking
천천히.
ready to the benches.
30 high pressure balloon, please.
3O high pressure balloon.
You know, if you do a tablator, you simplify all these maneuvers.
Okay, this is 3O.
Non-compliant.
Yes, 30 high pressure balloon. Break down the LED calcium first.
Okay, good. 14. 14.
16, 18.
16, 18. Okay,
Deflation.
looks like very acute angle. Okay, got it.
Okay, please give me the stand.
자, 스탠 주세요. 아까 나온 거. Okay. You're gonna do anchoring technique. 2.25. Okay. 이거 당기면 안 돼.
LED 6.
LED 6. Wonderful. Great.
Deflation.
Deflation.
It's good you already can
diagonal
crush
branch.
the stent.
6. Diagonal with 6.
자, stand is a 6.
Yes.
6. 6. 6. Just
8.
6. 8. Okay.
Deflation.
Deflate.
Long duration.
This is diagonal branch.
Right. We don't.
8.
Okay, diagonal branch 8. 8.
10.
10.
Deflation.
Deflate.
14.
Okay, the ostium of diagonal branch 14.
16, 18.
16, 18.
Deflation.
Deflate. Okay.
Please give me the 2.5 high pressure balloon.
2.5 high pressure NC balloon. Okay. Okay, this is a non-compliant balloon.
6.
6 NC diagonal branch
8,
6,
10,
8, 10,
12,
12,
14.
14, 14,
16, 18.
18,
Deflation.
deflate. This is a diagonal branch. This is LED.
So I can remove the whole system of
Okay.
diagonal. And then LED 18.
18. This is a non-compliant balloon.
Yes,
18. 18. Okay.
Deflation.
Deflate. 3.0.
14.
14. 14.
Deflation.
Deflate.
Ready?
Okay. Okay, much good.
Good. Perfect.
So please give me
Even the
the
second
2-5.
diagonal is not small. Huh?
Second diagonal is good.
You can
But,
do a tap maybe on the diagonal, just to
yeah.
make your life easier.
So, what size of a
2523.
2523?
2523 for the
Yeah,
distal
22?
distal
Yes.
part.
Yes.
Yeah, mid distal part.
Okay. So your plan, doctor, is to treat the bifurcation and then the proximal LED with different stents.
Yeah, right.
Yeah. Okay.
You're right. Because the distal is smaller than proximal. Proximal is a
And
3035.
there is
Distal is
that big
2.5.
septal that it may occlude when you place a stent in the
Yeah.
LED.
Okay, test.
We will wire the septal and dilate with the two balloons.
I think it's a good point to start by treating
10?
this distal lesion first.
10.
12, 14.
14.
Deflation.
Deflate.
16,
16.
18.
18.
Deflation. Test.
Okay.
Okay, 38, please.
Sorry, please.
30, 38.
So, and Jung-Min, Professor Antonio Colombo is concerned about the septal branch. What is your plan?
Just go straight.
Is your last word.
Would you show us the septal branches?
Yeah.
You may need another stent. for that.
Okay, good.
Oh,
It's already
yeah.
done. Gone.
See, it's gone.
Sure.
You should
Yeah.
never finish the case with less branches than you start.
All right. Side branches, right? Calcific lesion, that's getting more complex.
Okay, this is
Anatomy
38.
is simplification of the anatomy.
Okay, good.
Diameter
거의 들어갔나? 덜 들어갔나?
3.0.
This is
30.
30. Zero.
Yeah.
Okay, we're gonna stand boost.
Test.
좀 작나?
A little bit short, but I don't care.
한번
Place
부스트
another
한번
one.
아, 괜찮습니다.
괜찮아.
38.
Okay. 10.
Inflate 10.
10.
10. Okay.
So now, if you use a 3O balloon to
Defl-
post-dilate
terrible.
a little bit more distal,
Terrible.
you take the
Deflate.
risk of
Deflate.
closing the small
Yeah.
diagonal.
Yes.
Okay, good.
Test.
Okay, test.
I think we need a very short stent. Please give me the shortest one. Ready?
Okay, Angel, ready? Sure.
12. 35, 12.
35, 12.
Yeah.
Proximal part, very proximal. Would you want to do just a precise placement or just stent crossover over that?
Precise stenting.
Precise
I try
stenting.
to, but the maybe crossover. Maybe I will cross over circumflex too.
This is a 3.5. Okay.
35.
Yes.
이게 몇 미리? 12, 12.
테스트.
좀 맞춰줄게. 오케이, 굿.
테스트 one more. Okay, inflation.
인플레 6, 8, 10, 12,
10, 12, 14,
14,
16,
16, 18.
3.5.
오케이, 디플릿.
Deflation.
오케이, 굿.
Okay, let's just see what happened.
So you
Ready?
오케이, 엔저
deploy
레디.
the 3 stand.
오케이, 굿.
Very good. 2, 5, 3, 0, 3, 5.
To 5 high pressure balloon, please.
2.5, NC.
Okay, TW 작전.
So after-
okay, we gonna
Yes.
move another Calab and then we'll be back, right? In the last
Okay.
3. So
Okay, got it. Okay.
필영니, can you hear me? 필영.
이제 마무리하면 되겠다.
Yes, I can hear you.
Okay, can you hear me?
Can you hear me?
All right, great. So
Yes, I can hear you.
would you
Okay.
explain what you've
So
done?
this. Okay, this was the point that you saw last time, and I selected. As we know, there were the distal target of the LAD was 2.5 millimeter in diameter. So I selected 2.5, 32 millimeters of synergy stent, and after identifying the appropriate lesion, I thought this was okay, so I inflated it, and then proximally measured
Exactly
to the
same
potential
length of stand.
proximal LAD, and I selected another 32 millimeter of 3.5 proximal stent. And after identifying the appropriate position right
Right.
here, I stented it, 3.5, and hopefully the branches are okay. So I applied the 3.75 of high pressure balloon at the proximal and the mid, like this. And I applied the 3.0 high pressure balloon at the distal to mid, like this. So this is the result. And I would like to, I applied a little bit of more high pressure because after the I was finding there was a little bit of under expansion there, like this. And actually this is the final angiogram.
Great.
I would like to show you the I was finding.
All right.
The final I was, please. So this is the far distal LAD. The distal stent is okay. There is no malposition.
Good landing. Distal part. To more than
Okay,
2.5. Lumen area is more than 5, 6 something. It's great.
Okay, the diagonal is coming. The second diagonal is coming. I applied 3.0 high pressure to 18 millimeter mercury here. This is another diagonal, the proximal diagonal one.
What do you think, even with this nice result, what is going to be the restenosis rate at 2 years?
2 years.
2 years.
2 years restenosis rate.
Or the
Period.
TLR, whatever you
TLR.
want to call it.
What do you think?
2년째 리스테라시스 레이트 어떻게?
No answer?
좀 올려주세요. 잘 안 들려.
볼륨 좀 올려주세요.
Restenosis rate. TLR.
2
rate.
years, 2 years.
2 years.
Not 6 months, 2 years.
볼륨 좀
Even with this good result.
You have to make it, right?
I
And
would-
so
I-
based on our old registry data, we have the cutoff value up to 60 millimeter stent length is quite same with the proximal 40 and 50 something. Is that the reason why the effective, we can make a effective stent areas. However, more than 80 something that is cut off is our based on our data. The TLR rate quite high. However, still TLR rate, as I remember, just 8%, 9% still high, but acceptable. So.
But if you do careful follow-up with multi-slice CT, I guess it's going to be 30%.
30%?
Yeah.
TLR, you mean?
It depends on what is your
Alright.
trigger of TLR.
Even,
Many of these patients are maybe asymptomatic, not very symptomatic.
Right.
But if you really look deeply, the TLR. Some may be neoatherosclerosis, who knows?
it's great. Would you show us the left main part, in kind of a spider view?
Okay.
All right, would you check that one?
Okay. This actually this patient has a very short left main.
Mm-hmm.
That's
Is it good? All right, great.
and you can see by the IVUS that
I want to see that.
it's quite eccentric. The left main was quite eccentric.
That is very
Okay.
nice. What type
I
of,
was
what
touched
brand
by
of
this,
stent is
Okay.
very
This-
visible?
Main is okay?
Main is okay. There's a little bit of disease at the distal main, but the lumen is okay, and
A French
it's very
chider,
short, like this,
actually, the A
identical.
French chider is impact into
Right.
the main, right? Compared to the proximal part, did you see the IVUS for that? The main shaft area?
yeah. Can you see this IVUS? This is left main. The proximal, please. So, distal row, distal row.
Okay.
Okay,
It's good,
go.
good. Okay, great.
Actually, this is after the stent.
Okay, Pyong Lee, it's really a nice presentation. Good cases, difficult cases. You can make it simple, right? Thank you for your attention, right?
Thank you.
All right, we're gonna get back. Duk-Woo Park and Jung-Min.
Okay.
Where are you going?
Okay, this is the final step to the kissing balloon.
Okay,
This is
deflation.
1.5. Okay, go. 6, 8, 10, 12, 14, 16. Okay,
Deflation.
What size for
Okay,
the
one more
diagonal
time.
branches?
Okay, good. This is
1.5.
this is 1.5.
2 to 5 stem balloon, please.
You have to change
So
this.
we remained just the final kissing balloon step. Okay, 2.25. This is 2.25 used stand balloon, and then we already did high pressure balloon dilation from the distal LAD to the prox LAD using 3.5, and this is just last,
LAD 6, 8.
just last step. Okay, good.
Cross the finger.
Okay, got it.
Okay, deflation. Diagonal
Inflate.
6,
diagonal
6.
Eight.
Okay, okay.
deflation.
Deplete.
Still some indentation.
Okay, good. One more.
Dr. Park.
Six.
Okay.
Dr.
Six.
Park, I got a question.
Yeah, okay.
In the last two cases, the first stent, we may select 2.5 short stent
10.
based on the IVUS.
Microphone first. Microphone. Okay. Would you speak?
Deflation.
Deplete.
Uh,
You mean
why not
you mean
we
the
select short
we select
2.5 stent, the first
10,
stent, and then we can connect a bigger one based on the IVUS in the
Okay.
last two cases. Especially this one, the second stent 3.5 and the third one 4.0. I think it's better.
All right.
What do you
Do you
think?
mean the stent size? Stent size wise? Stent size is a distal part. They choose a 2.5.
Yes.
All right.
The last two cases, the operator all select 2.5 long stent, more than 30 millimeter. I think the short one may be better.
You
And
concerned
then the
about
second one, based on I was 3.5 stent. And then if you, to the left main 4.0, maybe the restenosis rate may decrease in future.
Right. Right. So, however, anyway,
So
recent.
and we yeah
recent, second generation Rodrigo stand and, modified, stand. How can I, the modification of a stand size is, even in the, we choose a 2.5, sometimes we're gonna make a 3.0, 3.2 something. We're gonna choose a 3.5, we can make a, 4.5, sometimes we're gonna make a 5.2, right? And so, there are some side, worry about the size discrepancies, choose the stand, however, we can modify more easily, high pressures. Then, okay, where are you?
Okay, just the remaining part and Jung-Min, and we'll do final high pressure for prox and distal prox LED also high pressure balloon using 3.5, and mid part bifurcation already did the kissing balloon dilation.
Dr. Antonio Colombo, I'm really sorry I cannot save the first second range.
It's okay.
Yeah.
I'm sorry.
You have to consider for septal branches.
10, 12,
14,
14,
16.
16. Okay,
Deflation. 18.
18, 20. Okay.
Deflation.
You want an epicaudal view? It's
No,
okay?
no, it's okay. 20.
Okay, 20. Okay.
Great.
Okay.
Okay. The balloon is very expanded, no indentation.
Yes,
so
yes.
I'll like finish my procedure.
Okay, got it.
Test, please.
Okay, test split.
Andrew? Great.
Okay.
Okay, and you're ready?
First diagonal branches crushes, the second diagonal
Okay,
branch
got
is
it.
saved.
Yeah.
So,
doing
consecutive series, right? Picture again.
Ready?
Okay, nice.
Great. So, Dr. Han, what is the last message from this case?
Yeah.
Calcific
Nobody
region,
knows the fate of diagonal.
상체 옆으로 좀 가봐.
calcific region just to,
Okay.
non-compliant
Ready?
high pressure, almost 28 atmosphere, may work for, many
Okay, nice.
cases of heavy calcification. That is the message, right? All right.